This morning. I'm Brian Flaherty, Methods Core Director in BIRCH, and we're very happy to have Professor John Jackson from epidemiology at Johns Hopkins joining us this morning to present some of his work. And Dr. Jackson earned his PsyD in epidemiology from Harvard, and his research focuses on methods for understanding health equity and health disparities, and also causal inference. Dr. Jackson said he has about 45 minutes or so. So we should have some time at the end for questions, but also if there are questions in the middle, that he's open to that too. And I'll be monitoring the chat to so he doesn't have to. And so if you have a question in the middle, and you can put it in the chat, and I'll be paying attention to that. And then I'll try to wait for a moment to interrupt him, and then he can address the question. So I won't take up more time. Thank you, John. And please, the virtual floor is yours.
Thank you. It's an honor to be here today. Really excited to present to you. And I just want to reiterate, I'm totally open to questions. I intended this as a more accessible, high-level talk, but if there are more, substantive questions or even like really technical questions, I'm happy to field those throughout or at the end. And so what I'm talking about today is and concepts around how we think about measuring disparity, which I think many of you will be familiar with, but I like to open up with those. And then I'll be talking about causal decomposition analysis, which is an approach I've been working on to inform interventions to reduce disparity. And I want to be honest and say that, it's not the only approach out there to do that. There are of course, other analytic approaches, but there are also, I think, qualitative approaches that can be useful too. And I think it's worthwhile to say that all of these can be used in concert. There are some strengths about this that I like, and I'll sort of touch on those throughout the example. So we're going to start off really broad and again talk about definitions of disparity. For those of you who aren't in health services research or health economics, I'll introduce this notion of allowability, which kind of is moving from this broad step of how do we define disparity to sort of what do we adjust for when we measure disparity and why. And then using those ideas, we'll use those ideas to really unpack what's going on in causal decomposition analysis. If you're interested in this work at all, there's two papers I would recommend. The first is this paper, Meaningful Decompositions in Health Equity Research, which was published in Epidemiology. And there is an archive version up. So this one really builds out sort of causal decomposition analysis, talks about allowability. So it's pretty much what I'm going to cover in this talk in a lot more detail. And then there's a second paper here that's actually I should update this reference, but it's now on and it's now in the American Journal of Epidemiology, and it's the importance of equity value judgments and estimator alignment in measuring disparity and identifying targets to reduce disparity. So a common theme of this approach that I'm going to present is that, we start off by asking what is it that we think disparity is, and then we do some causal inference on that definition of disparity. And the key part there is that we have to make sure that this initial part about what we mean by disparity is reflected. Otherwise, we can think of that as a form of bias. I think someone.
And people, please mute.
Yeah. And so uh, so that's the big part there is that, you know, if we just like in any statistical analysis, if we are estimating something that doesn't really target what we want to know, we're sort of getting the wrong answer. So this kind of underlies scenarios where that bias might be large and also provides some code to implement the approach. Um, so I'm going to use a motivating example. I know that the center focuses on mental health, but I think some of these things are transferable. The outcomes I'm looking at are hypertension control within a healthcare system, and looking at whether or not bias in treatment intensification, um, whether or not disparities in that actually impacts disparities in hypertension control. And so we want to both measure disparities in hypertension control, also perhaps treatment intensification, and then understand how those disparities in treatment intensification impact disparities in hypertension control down the line. And so you could assume that you have like electronic medical records for primary care visits. Um, yeah, you could assume that's sort of the data land that we're working with, or perhaps, you know, there's a study that has things measured nicely. So let's get started. So we're going to talk about what is disparity. Again, I like to start by just saying what is a disparity. I think there's like a lot of variation in the field when people talk about it or do methodological work on it. Some of the earliest definitions, well, this is definitely not the earliest, but one that's very popular is the Institute of Medicine, which is now the National Academies of Medicine. They say that racial and ethnic disparities in healthcare, and that's the key emphasis here, are differences in the quality of healthcare that are not due to access-related factors or clinical needs, preferences, and appropriateness of intervention. And in that report, it came out of the unequal treatment report back in 2003, and they were really focused on disparities at the healthcare system level, which encompass everything about the legal and regulatory climate in which those systems function. And then they're also interested in discrimination at the individual or patient provider level. So sort of two ways that sort of disparities could arise is what they were interested in. And so I think there's some things that are nice to pick out from this definition is that one, you know, I'm an epidemiologist, so a lot of times we think about health outcomes, but it's nice to like emphasize that we can talk about disparities in actual receipt of treatment, and that has different implications for how we measure disparity. I think this notion of scope is important. Are we talking about at the provider level, at the health system level? And then what I'm going to really focus on in the next section is this notion of what are relevant differences that we want to sort of assess, right? So maybe not all the difference that we see may be reflecting discrimination or other things that we might think of as unjust. Like there may be differences that may be allowable per se. And this really comes up when we think about disparities in healthcare utilization. The next definition is one that's widely used, and it really goes all the way back to the World Health Organization with Margaret Whitehead. And so it's kind of grown over the years. Paula Braveman sort of built upon it in 2006. And this is sort of what Paula Braveman and colleagues have used for the Health People 2020 report. They say that health disparities are systematic, plausibly avoidable health differences that adversely affect socially disadvantaged groups. They may reflect social disadvantage, but causality need not be established. And they grounded in ethical and human rights principles, focusing on the subset of health differences reflecting social injustice, distinguishing, sorry, my Outlook just popped up a calendar. Okay. Yeah, distinguishing health disparities from other health differences, also warranting concerted action from health differences in general. So key features that I pick out here are like one, we're really centering socially disadvantaged groups, and they really emphasize that these are groups that have experienced long-standing social exclusion and oppression in society. Large part that's, politically driven, also economically driven. And so that's what they mean when they say socially disadvantaged populations, right? And one thing that's implicit in this definition is that they're really concerned about differences where these disadvantaged populations are further disadvantaged on their health. And so they're looking at that as a disparity. You can find instances in medicine and public health where socially advantaged populations are doing worse. And so this definition is not saying that, that's not morally problematic or it's not something that you would be concerned about. But for the purpose of calling something a disparity and putting disparity sort of policies around it and efforts and targeting and that sort of thing, we're really interested in the subset of differences where the socially disadvantaged people have undergone long-standing oppression, marginalization, are really doing worse in terms of health outcomes. And plausibly, there's this notion of avoidability. I think they mean that in the broadest sense possible. So not necessarily what we have policies to ameliorate today, but what we could if perhaps we put forth enough effort or enough scientific development to actually address these things. Now they are really, focused on things that really at the heart reflect some notion of social injustice, which leads me to the next point is, this notion of causality, which is, really interesting. And so what they say here is that, in order to think of a disparity as something that's morally concerning, it's not necessary that we have like the smoking gun or the magic bullet to say, okay, A led to B led to C, or we have the causal effect of, say, race or discrimination to prove that this is the mechanism by which it happened. That's not what they're really grounding their notion of injustice in. What they're really making their argument on is this human rights perspective that when people who have been socially marginalized and oppressed in society, that these disparities in health actually impact their economic prospects, their well-being. They have forward-looking impacts, right? And so that these disparities in some sense have an impact on their human rights. And the human rights argument cuts, I think, for everyone, but in particular, I think they do ground this notion of disparity as something that has moral weight to it. And so, they say that causality can be helpful in talking about disparity, but it's not something that we need to do to justify it or as a problem of concern. The last definition I'll pick out here is the National Institute of Minority Health and Health Disparities. They kind of riffed on that definition to put a little bit more nuance to it. And so they say, again, they're really looking at things where they have, they call these socially disadvantaged populations, actually define disadvantaged populations. And that includes, groups like racial and ethnic minoritized groups, persons with lower socioeconomic status, underserved rural communities, sexual and gender minorities. I think they have just added persons with disability status. And then also, I think I would make the argument you could probably include persons with serious mental illness in that camp. At least NIMH would agree with that. And so they kind of, make it a little bit more nuanced that we can talk about outcomes along the whole spectrum from incidence to prevalence, talk about onset or prognosis, and even patient-reported outcomes. You'll notice that one thing that they do not do is they don't really harp on sort of, this hypothesis of disparities being driven by social mechanisms. And I think that was intentional in the fact that sometimes it's hard to draw the line between a social mechanism and when it bleeds into a biological presentation. So one of the examples that they gave were, disparities in cancer presentation. One person might look at that and say, oh, it's the tumor subtype, et cetera. It's a biological thing. Whereas it's actually more nuanced than that. It could be due to their environmental exposures that they've had. And so there's this complex interplay there that, is definitely socially driven, but can manifest itself in ways that seem less social. So I think they wanted to acknowledge that complexity. So now that we have that definition, let's talk about allowability. So that's going back to the Institute of Medicine. So, and this really gets to what covariates do we adjust for when we actually measure disparity. So if you go back to the IOM definition, they said that, let me just cycle back really quickly. So they said, we're looking at disparities in healthcare. That could be what type of, in our example, that could be whether or not your treatment's intensified. And those differences that they see that are going to be disparate are going to be ones that aren't due to clinical need, right? So, it shouldn't be due to differences in your blood pressure that you present with or your comorbidities. It should be due to something else. And so for them, the crude difference isn't really disparity in those circumstances. And really, what we're interested in, the disparity that captures differences that are morally concerning. And covariate adjustment helps us do this. And so the big question is what covariates do we adjust for, when, and why? And so in the paper that I referenced earlier, Meaningful Decompositions, I pick out sort of different principles for health outcomes and also for healthcare outcomes that I've seen in the literature. And I'm not necessarily, I have a bias in terms of, the principles I like, but the paper was just to sort of put out principles that are out there. So one argument that you'll see out there is this notion of modifiability, right? And it's kind of I think, focused on this notion of accountability. Who's at fault? So you want, someone's at fault, you kind of want to take off the table things that they have no control over, right? And so it's for these reasons that you'll see, differences in covariate distributions that are non-manipulable from the point of follow-up would be sort of adjusted for. So one that I've seen in the literature is people might adjust for genetic markers, right? So if we're looking at disparities in cardiovascular disease, some people would adjust for SNPs measured at baseline because, hey, we can't do anything about it. The other thing that you often see in EMR studies, at least this happened during COVID, a lot of times you saw the disparity studies, they were adjusting for pre-existing conditions because, hey, when they get to the hospital, they already had those conditions, they can't really change them, et cetera, right? So this notion of, hey, the scope at which we're looking at, they don't have control over it, so why is it unfair? There's a principle of amenability to intervention, which was, I first saw it in a paper by Julio Frank and colleagues, where they were really making a counter argument to that, to say that, hey, if we have interventions that could potentially, or we could develop interventions that could address the effects of those disparate distributions of things that we have no way to change, right? We have no way to change the value of someone's, if they've had a heart attack already, we could at least give them appropriate care or target interventions. And if that doesn't happen, it can be thought of as inequitable and unjust, right? And so this is really focused less on who's at fault versus hey, this is a problem. It needs to be addressed. We need to respond to it. So even though those differences may not be, fully changeable, we can at least respond to them and improve outcomes, right? And so, you know, the caveat here is that sometimes those baseline differences may be things that place marginalized groups at an advantage, right? So in clinical samples, you may see marginalized groups be younger due to demographic distributions. And so in those cases, maybe you want to adjust for those so that you don't underestimate disparity from perhaps other sources. So now we get to healthcare outcomes. And this perspective, I think, is implicit in a lot of labor economics, and also I think it shows up in algorithmic fairness now. But this is like where we're talking about how should people be treated, right? So are there differences in treatment? Are those disparate, which kind of ties back to the IOM definition. So I sort of think of it, broadly speaking, as falling under this notion of a social contract. If you're a philosopher in the room, I realize you may have issues with that framing. I sort of mean it as a broad social contract that one could propose that one believes is equitable, right? And so based on the criteria in that contract, one that we perhaps have agreed on or could all agree, those criteria should ideally be what's governing how a good is distributed, right? And so those criteria would be the allowable factors. So in our hypertension example, that would be things like blood pressure. It might be whether or not you have diabetes or chronic kidney disease. If the clinical guidelines suggested different thresholds for people at different ages, those sorts of factors would be allowable, right? So the focus here is that we're really interested in relevant differences, right? Because the idea here is that if we had people who are aligned on these allowable criteria and things were operating equitably, we shouldn't see differences in treatment, right? If we don't see that, then we have concerns. And so some examples, just to kind of bring it home before we get into the decomposition, if we have racial disparities if we want to measure racial disparities in hypertension control, should we adjust for pre-existing conditions? Well, like I said before, from the principle of modifiability, people would say yes. From the perspective of amenability to intervention, that we have clinical guidelines that actually respond to pre-existing conditions, right? And so to acknowledge that, the amenability to intervention perspective would say, no, we shouldn't adjust for those when we're measuring disparities in hypertension control, especially because the marginalized group is disadvantaged on these. They usually present with more pre-existing conditions, which means that it's actually what's driving the worst hypertension control among that group. What about things like type of health insurance or other markers of socioeconomic status? And let's say we were going to look at post-surgical outcomes. Well, in some sense, this is just like, this whole pre-existing conditions notions. The marginalized group usually, may have a higher prevalence of less flexible insurance or less coverage, or perhaps a lack of coverage. And that is, again, what's driving this, the worst outcome among the marginalized group. So we wouldn't want to adjust for it, even though it's, even though perhaps the hospital can't change what insurance they have, they can still provide the best possible care to improve outcomes. What about when we're looking at utilization outcomes, right? And we're asking about these same covariates. Should we adjust for pre-existing conditions? Well, on the IOM definition, if we think about clinical guidelines, the answer should be yes, because those are relevant. Those are sort of fair differences, right? So if the marginalized group has a differential distribution of pre-existing conditions, and those lead to differences in utilization, those differences stemming from that aren't necessarily, those are reasonable, right? Because you want people to be treated based on their clinical presentation. Should you adjust for type of health insurance? This is an interesting one if we think about social contract, because you could say, well, in the US, we have a social contract where we require, where what the treatment you get actually does depend on what you have. But I can't think of any clinical guideline that I've seen that dictates the best medical course based on the payment mechanism, right? So if we're thinking about things in an equitable sense, we wouldn't want to adjust for things like type of health insurance or socioeconomic status or ability to pay when we're thinking about measuring disparities in healthcare utilization. So with those ideas about what is disparity and also what is allowable, let's talk about causal decomposition analysis. I've been harping a lot about this notion of equity, and I'm going to be presenting something that brings in ideas about causal inference. But I could just someone may raise their hand and say, "Hey, wait a minute, decomposition, that's an old technique. It goes back to the 70s. We've got regression. Like, why do we have to do all of this stuff, right?" And I think, our standard approaches, they have been used to measure discrimination, and they have been used to inform intervention. But I'd say that they fall down in two areas. One is that I'll start with the second one. In ignoring issues of equity, it really ignores everything we just talked about, right? So if you put, if you have a variable race in the model, and let's say, you want to account for things, right? You can't really make distinctions between like what's in there to control for confounding, what's in there to measure disparity. It's all kind of all the covariates, it's all fully stratified. And so it doesn't allow you to map your statistical estimate to like your notion of what an equitable versus inequitable difference is. The other part I probably should have started here is that, they can ignore issues of causal inference. And so with the Oaxaca blinder decomposition, regression, usually, people are looking at factors, but they're not throwing in, variables to rule out an alternate explanation of some third unmeasured factor that's really driving the difference. And so you could be identifying factors that seem to explain the disparity, but aren't really causal. And so they're not necessarily appropriate for building the intervention around. And so you have this interplay between these two ideas where you need to incorporate confounders, variables like SES, type of health insurance. But when you do that with these techniques, automatically you're kind of mucking up your definition of equity, because now you need to look among everyone with the same health insurance or the same SES. And so causal decomposition analysis allows you to separate those two issues. And so I'm just going to motivate it with like a high level scientific question that we could ask with it is, how do racial disparities in hypertension control, if we were going to treat demographics as allowable and balance those across racial groups, how do those disparities change when we equalize treatment intensification rates within levels of demographics and clinical factors, right? So we want to measure disparity by adjusting for, say, age and sex or sex assigned at birth. And then we want to equalize treatment intensification within levels of factors that may represent clinical need, and ask how that disparity would change. And if we saw a big change, that would sort of give us a sense that treatment intensification would be something that we would want to build, or at least include as part of an intervention. So I'm just going to give a quick cartoon. So we have, say, our observed scenario for, say, the Black population and the white population. The Black population is treated at a certain rate or intensified at a certain rate, and that leads to hypertension control outcomes for them. The same thing for the white population, they're intensified at a certain rate, and that leads to hypertension control rates. And then the observed disparity is just contrasting these two outcomes. And then we have this counterfactual scenario where we have the Black population under a hypothetical scenario where we've removed the disparity in treatment intensification. So now they're getting intensified at the same rate that the white population is intensified at, and that changes their outcomes. So one thing my colleague really pointed out to me, which is like, in this approach, you'll notice that the Black population here is still Black, right? They haven't been, their race hasn't been changed. What's been changed is, how they've been intensified, and that has sort of impacted their outcomes. So we haven't really changed anyone's race. We're just changing how things are distributed in the population and asking how that impacts outcomes. And so that leads us to two sort of estimates that we might be interested in. One is this disparity reduction. So, and that's going to contrast the observed scenario for the Black population versus its counterfactual scenario. And that's how much the disparity would change, and then how much the disparity would be left on the table. We're going to contrast the counterfactual scenario for the Black population, contrast that with the observed scenario for the white population. And I'll say, we can get into this in the discussion, that there are many intervention strategies you could imagine. This is just one particular one where we equalize by setting the rates of treatment intensification equal to the rate found among whites. You could imagine many other things, and that's totally doable. So again, getting back to the scientific question, how do racial disparities in hypertension control standardized for demographics change upon equalizing treatment intensification rates within levels of demographics and clinical factors? Key points here are that, one, only demographics, and I call those outcome allowables, are used to define the disparity in hypertension control. And then B, only demographics and clinical factors are used to define the intervention that we're using to equalize treatment intensification, because it's happening within levels of demographics and clinical factors. And then what you'll notice here is that other variables like socioeconomic status are non-allowable, because based on the arguments we made earlier when we opened up, they're not used to define disparity, either in terms of our outcomes or what we're trying to equalize, right? So it hasn't shown up yet. So, those are the key points. So really, causal decomposition analysis is really an approach that allows us to make and incorporate these allowability judgments, so that, number one, we have an appropriate measure of disparity for our outcome and an equitable equalization for our explanatory variable. And it turns out that during the estimation process, you can use additional variables, such as the non-allowables, to account for a potential bias, such as confounding or selection bias or other things. But it's kind of like it's an ingredient, but it doesn't really show up in the scientific question, right? So it's something that helps us. These non-allowables help us answer the scientific question, but they don't define the scientific question, right? So if we go back to this slide here before, the non-allowable didn't show up at all in terms of how we were defining disparities in outcomes or how we were equalizing. But it turns out that in the estimation process, we can still use them to address for things like confounding. So other approaches, so it turns out that, like, under certain choices of allowable, of what you choose as allowable or not, you can recover certain statistical estimators that are used for other things in statistics and epidemiology. But if you go directly to those estimators, you're sort of relying on their choices that are being made for you, right? Because they've sort of said what the disparity measure would be, and they've said what the equalization would be. And if you start from this causal decomposition analysis, under some choices, you may arrive at the same place, or you may arrive at a different place. And so it allows you to sort of make that decision on your own. So as an example, the standard estimators for natural direct and indirect effects, or their analogs, would over-adjust the disparity measure by adjusting for clinical factors and socioeconomic status, because you would need that to account for confounding of treatment intensification, which would violate the principle of amenability to intervention. And it's also an inequitable equalization, because the equalization is all within levels of SES, right? So we're basically saying we're going to equalize things for people who can't pay, which isn't much of an equalization. And then we're going to equalize things for people who can pay, which also isn't as much of an equalization. It's really equalizing, ignoring the ability to pay, that really cuts at the issue that we're trying to address. So again, back to our scientific question here: how do racial disparities in hypertension control, standardized for demographics, change upon equalizing treatment intensification within levels of demographics and clinical factors? And we're going to answer this question by comparing hypertension control in the observed scenario for the Black population, contrast that to the counterfactual scenario where we remove the disparity in treatment intensification. And that's going to give us how much the disparity would be reduced. And we can ask a similar thing to get to the residual disparity. So this is like the most math in the talk. It's just for those of you who want to see things notated, because some of the formulas I'm going to use in a second. So R is race, Y is hypertension control, M is treatment intensification. Said before, AY is our allowables. I'm going to come back to T. AM is the things like clinical need. So these are things like that are that we're using to equalize, or using to like define our equalization. So things like systolic blood pressure, these are the target allowables. And then we have this potential outcome, Y of G. And this is really just saying, what would someone's hypertension control be in the Black population, given that we've redistributed treatment intensification so that it follows the distribution of treatment intensification down among the white population, who have the same level of clinical need factors like systolic blood pressure and demographics, right? And so here you can see that we're basically just contrasting standardized means, one that's observed, quote unquote, and one is based on a counterfactual. So what's this T here is that it's more general in the sense that, like, when we talk about defining the disparity in hypertension control, we have to choose a standard distribution for the demographics, right? And so we could choose that to be the marginalized population, which kind of centers them, which would make this their crude estimate or unadjusted estimate for hypertension control. We could also choose other things like an overlap population. We could choose the privileged population. We could choose the combined population. But this is also a choice that we have to make. So there are some causal assumptions. I didn't write out the notation, but I think they're pretty mild compared to some of the other approaches that you could use. One is that we need overlap in the distributions of our explanatory variable, like treatment intensification, as well as the allowable covariates, so like, say, demographics and also factors that represent clinical need. We need overlap across race. We also need no unmeasured confounding for the effect of the explanatory variable, treatment intensification, on hypertension control, our outcome, given our allowables, so like factors that represent clinical need, and also the demographics, but also non-allowables as well. So like if there are other variables beyond the allowables that could confound the effect of our variable like treatment intensification on the outcome, we can include those two to meet this assumption. We also need these are more technical assumptions about sort of observing so yeah, I think the positivity assumption here, you could say that we want to observe rates of treatment intensification among the levels of the covariates among the marginalized group. The subtle point here is like you want to observe the pattern that you see in the privileged group. right? So if there are certain covariates where among the privileged population, everybody's treated, that's okay. You know, what you don't want to see is like cases where in the marginalized group, people are never treated, and that you don't find that pattern in the privileged group. That's where you run into problems. And then you have consistency. This is our standard SITFA. And this is, I think, reasonable in many instances. You know, this is a well-defined intervention in the sense of like, you know, we can manipulate treatment intensification. Where it gets a little fuzzy, I think, is this notion of if you intervene to make things more equitable, the system doesn't always respect that, right? The world changes in a sense. And so in this example, I think this is pretty plausible, but you can imagine other things that if we equalize them, all hell would break loose, or, you know, and I mean that sort of facetiously, but, you know, things would be contested, et cetera, or the world could just look different. You know, the way that outcomes are distributed could just be, it could, in order to achieve that equalization, a lot of things would have to change, right? And so that's a really tall assumption that I think isn't always recognized. I have a commentary that sort of talks about that. So onto the estimation, and then we'll wrap up. So this is really a really simple approach by weighting. So the observed disparity, if you're familiar with stabilized inverse probability weighting, that's really all we're doing here. Replace your confounders with the allowable covariates, and that's what you get. So here, this is going to be a weighted difference, or difference of weighted means for hypertension control, comparing blacks for whites with race-specific weights, where the weights for blacks is going to be, the numerator is going to be the probability that they are black, and then the denominator is going to be the same probability, but conditional on, say, age and sex or the demographics. We have a similar setup for the white population, the probability that they're white, and then on the denominator, given age and sex, and we can estimate those using models. For example, here, we just have logistic regression. So this counterfactual thing, yeah, this is supposed to be black here. I didn't change this. But this counterfactual here, right? So we know how to get this guy. It's the same weight as this. How do we get this guy? And we essentially have this density ratio here, where the denominator is the observed distribution of treatment intensification, given that they're in the black population, given the non-allowable socioeconomic status, this AM, this clinical factors representing clinical need, these target allowables, additional target allowables, and then the demographics. And then on the numerator, this is our interventional distribution. This is what we want to see in our counterfactual. This is the distribution of treatment intensification among the white population, given factors represent clinical need and also demographics. And we multiply that times that stabilized inverse probability weight that we had before. And again, we can estimate both the numerator and the denominator using models. And so we talked about how to get the observed disparity. The reduced disparity is just going to be, you know, the difference between those two means, and the residual is going to be the difference between the weighted mean that gives us the counterfactual versus the weighted mean for the white population. And we can bootstrap to get our 95% confidence intervals. So to wrap up, allowability is a central concept in disparity measurement. It says what covariates should be balanced across social groups. And I'll acknowledge it's a value-laden choice that really requires a lot of discussion, but it's something that we can't really bypass if we want to get like really meaningful and thoughtful estimates. Disparity can be decomposed using causal approaches that really focus an intervention on the explanatory variable. So we're not really intervening on race here, but we're just intervening on the things that we would want to change. And then in causal decomposition analysis, we start with a meaningful measure of disparity. B, we have a meaningful equalization that's only within allowable factors, within levels of allowable factors. But we can incorporate other variables to address potential confounding. without changing how we've measured disparity and without changing what we think is a meaningful equalization. There's some further papers. So these are all the definitions that I talked about before. I think they're great reading, actually. And then here's the two papers I mentioned before, and then there's work that this kind of expanded out of work that I did with Tyler on decomposition analysis, but this paper didn't really build in the equity value pieces that I talked about here. But it's very intuitive, I think, because we do everything in there with linear models. So that's the end of the presentation, and happy to take questions or conversation.
Thank you very much. It was very interesting. There's a question in the chat. I don't know if you want to take a look about a target allowable. It just showed up. It's not old.
Okay, let me see if I can get back to that.
Oh, is that not easy? I can read it.
Should I stop sharing my screen?
I don't know if people might want to go back. This is about the
I can get to the
AYAM
chat.
target allowable, and would it be possible?
Okay.
I don't know if
There
that
we
would
go.
reference a slide, if not.
Yeah, I can see it. Could it be possible that not all variables are, so the answer here, this is a great question, very you were paying attention. So I have not yet found an example where something that is outcome allowable is not also target allowable, because you're sort of starting within, you're already making the assumption that the relevant disparity there is accounting for these outcome allowable factors, right? So in my mind, that's implicitly making them target allowable. And I can't think of there may be, and I'll acknowledge that there may be, and this may be your oversight, there may be a scenario where you would want to break them up. I just haven't found a compelling example yet where that would be the case. If you have one, I'd love to hear it.
Yeah, please.
Okay, so but yes, you're right. Like what you read there was right, is that like outcome allowables are kind of factored into the target allowables. Yeah.
Okay, thank you.
Great question.
Other questions?
Anything you want to debate or ask questions about, like you want to ask?
Oh no, I'm just curious about this question because it seems like there are three sets of variables. The first set is like a set of variables that is only outcome allowable. The second set is like only target allowable. Like maybe so in your case, all target of like I think in your case, or all outcome allowable variables are a subset of like target of allowable
That's correct.
variables.
Yes,
Yeah.
that's correct. Yeah. The AM are like extra target allowable.
Yeah.
You got that right.
Yeah, I just curious if it is possible, like it's not a strict subset of like target allowable like variables.
I mean, one question would be is like the other way around is like, are there variables that you would want to equalize that shouldn't be used to define the disparity?
Yeah, that's true.
Yeah, that's one way to think about it. So it's like, would you want to account for these in the equalization to make it fair, but it wouldn't be fair to, it would mischaracterize disparity to like use them to measure disparity in that sense. That's a different, I think, that's the question I ask myself, and I haven't found one yet. But again, I could be wrong, or just, like just not stumbled across that scenario yet.
Okay, thanks for your explanation.
Oh, thank you.
Yeah, John, really thank you for a great talk. Yeah. Ray is a biostatistics PhD student working with me actually. So he has been paying attention to your papers. Yeah. So I guess sometimes like as biostatistician, we are very, very used to like confounding control, but then I guess sometimes I guess when we're trying to think about what's, I mean, well, I guess that your definition is like really enriching, like us to think about like the different way to define the problems. But I guess it's just sometimes a little bit hard for us to think about what should be in each categories.
Yeah. No, that's a great point. And I mean, I think it's a hard, like asking a good scientific question is just hard, right? So I think part of it is, so this is why I took the approach that I did, in that, like, in the paper, I don't tell you exactly what should go where. I just give you the choice, right? So, and that means that when you do this work, um, people who are using it can have conversations with stakeholders, with people who are knowledgeable, who are experts. Um, you can have conversations with community members, and you can all reflect on, what should be there. And I think that's what I'm encouraging, I would say, in a sense, maybe even biostatisticians to do, is present estimators that give people options, right? Give them the give them the power to say how should the estimand itself be defined when we have to control for confounding and those sorts of things. It's a little much because, the users will then push back and be like, whoa, 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 wait a minute, this is hard. You're making me think, like, and I don't mean that in a bad way, but it's like, it's an extra thing to ask of people. But I think it's a good thing to ask of people. It's no different than asking, like, are you interested in the effect on the treated or on the entire population, or, those types of questions. Yeah, that's kind of the spirit of it.
Thank you. I do have a question which is slightly, well, it's related. You've actually mentioned it a bit, but I just want to hear your opinion on this. Is like you mentioned, like different clinical cutoff maybe for different race, and then has been like a lot of debates whether we actually should use the same cutoff or not. Like there's a biological reason, or there may be like that. But using a different cutoff might be actually getting inequity. I guess I just want to know a little bit more about your thoughts on this issue.
Yeah. So you're asking me to give a different talk, but no, but this is a good question. And I've thought about it some. I'm still thinking through it. Um, I'll say, I think at the outset, that I've always been suspicious about race-based medicine. Like, when, if I go to the doctor and they tell me, let's say, one of my friends was diagnosed with hypertension. I've heard people say this, like, well, this drug doesn't work as well for Black people. And I know that, it probably was some like ad hoc statistical, analysis that was done on the back end of a trial. And, there's not really good. So I've always been suspicious of those things. But then on the other hand, there's this notion of, like, how much data do you have for a particular group, right? And, and also, like, are you accurately reflecting either the distributions or the mechanisms for that group, right? As opposed to assuming that everyone has the same experience, right? And so there's this trade-off between, are you reifying biological difference versus are you giving people the best prediction possible? And there's been some interesting papers that came out. I think you may have seen this paper. It came out in PNAS by oh my gosh, he's a household name economist, and I'm blanking. Uh, uh, I forgot his name, but please forgive me. But anyway, he had an interesting paper that, really thought about it from a utility perspective. And so I can see that viewpoint of thinking about whether you should fit a race-specific model or not, in terms of what's the impact that it has on outcomes. Like, is it harming, or is it actually improving. So you have to think about, A, what's the purpose? Like, is the purpose of the model to make decisions? If it's not, and it's maybe to reflect risk or describe risk, especially due to like social, to, maybe put a label and say, hey, this is the level of social disadvantage someone's having. In that case, you probably do want to throw in all of these factors, right? But if the purpose is to make decisions, then you really want to say like, well, what's the impact of that decision going to be on, like, at the population level, but also on disparities themselves. And you can make the argument that if it's going to increase disparities, that you wouldn't want to include race. And I think that's where the EGFR stuff fell out, is that when they looked at the data, they found that including race made things worse in terms of getting access to kidney-saving treatments and to transplants and those sorts of things. I'm still thinking through it, but that's kind of where I'm leaning, because I think you can find other examples. I think Tran Nguyen and a colleague at they did a session at JSM where they, one of the presenters showed, like, if you left race out in a different example, I think it was a cancer example, that you actually did harm because the predictions were worse. And I think you could make an argument on ethical grounds that it would be better to include race in that example. So yeah, I hate to say it depends, but I think it does depend.
Yeah, thank you very much. Yeah, I'm asking this because I have been start thinking about it. There's a new NHLBI Asian cohort that I'm involved in. So yeah, we are going to face this kind of stuff.
Yeah, it's tough. It's tough, but I'm glad you're doing it. And yeah, I think the key is, like, whether you leave it in or out, just have a good justification for it, and people will debate it. And but I think on the grounds of like actual impacts, I think that's a strong rationale. If an algorithm is going to do harm, you don't want it to do harm, right? So I think that's a fair thing. And of course, there's the whole meta thing of like, if it is in there, then you need to be explicitly clear that, like, this is what it's picking up, right? Is it that we're not picking up biological differences? We're picking up exposure to structural injustice, et cetera, other things that aren't reflected in the data set. And maybe in some instances, for some diseases, maybe there are like genetic differences, like, like in malaria or something like that, like, or skin cancer or whatever. Like, maybe there are differences there that are relevant, but those are probably the minority rather than the norm.
Thank you very much. I want to be respectful of your time. It's 10. It's 10 here, so it's 1 there.
It is.
But thank you very much. It was